Hello, everybody. We have a wonderful day today, and on behalf of our academic community, I have an honor to welcome Cecilia Mascolo. Academic community, I have an honor to welcome Professor Cecilia Mascolo from the University of Cambridge. Professor Mascolo is the head of the Mobile System Research Laboratory, as well as a co-director of the Center for Mobile Wearable Systems and Augmented Intelligence, University of Cambridge. She is a world-renowned expert on the application of mobile technologies, machine learning, and audio-based mobile health systems and diagnostics. And I would like to cordially invite Professor Mascolo to share with us her unique knowledge on mobile health systems. And for the audience, please feel free to ask questions on YouTube live chats. After the presentation, we'll have a Q&A session. Professor Mascolo, the virtual floor is yours.
Thank you very much for this invitation. I am very flattered, and I hope the presentation will be understandable. I will now share my screen, and we'll take questions at the end, but I'm happy to have a conversation about these aspects with you. I hope you can see my screen, and I have a slide about myself, and then I will introduce the topic of the talk. So I'm a computer scientist by education, but I've always been interested in applying the science to other disciplines. And this has ranged from trying to monitor the behavior of animals, such as badgers. There's a badger there with a collar with an RFID tag. We have badge people, again, with RFID tag and watches to understand their behavior and their well-being. We've done emotional analysis of their emotion. We have built devices to monitor physiological signal from the ear, from hearables, and that's what we're doing these days. And at the bottom there, this thing is a rudimentary audio belt that we thought we would use to understand sounds of the body for medical purposes, of course. We also analyze data that comes from these devices. One of the studies I will talk about is a study related to COVID, and we collected a large data set of sounds, and I will tell you more about that. And this is related to health, so it's relevant to this talk. So what is mobile health in my mind? Mobile health tries to make use of digital technology, in particular wearables, and their sensor to proxy information about behavior and ultimately also as health. And I hope in this talk to give you an example of how these techniques have been used for understanding health. I think many of you probably are already wearing some of these devices. In particular, I'm wearing things I put in my earpods, but obviously I generally have a watch on me as well, a smartwatch on me. Why would we want to do that? Well, I think I'm spelling out things that are probably kind of obvious. It's clearly scalable as a technique because many people already have these devices in their hands. And so the ability to monitor as well as perhaps give advice through those devices could allow us to reach large number of populations. And it could be affordable to do so because some of these devices, not all, certainly a smartwatch, an Apple smartwatch, for example, is still quite expensive. But there are already companies providing cheaper versions of some of the subsets of features that these devices are producing. And certainly some of the sensors on these devices are quite cheap. A microphone is very, very cheap. Continuous. Often we have the ability to have information from these devices that gives us a view that is almost unprecedented. First, people were going or are going to the doctor and get checks, expensive checks every now and then, and possibly once a year, once every 6 months, or if it's something is found in the health, then a bit more frequently. But these signal will be continuous almost. We'll be able to get a very fine-grained view of the health of these people. Now, that means also that it might not matter how precise the signal, how accurate the signal is, if you can trade off accuracy with continuous signal. So there are, I think, some pathologies where having a continuous view is more important than having a very, very precise signal. And this would mean cheaper devices, possibly. But these are all challenges and things that we can work on. Some of these techniques substitute some more invasive techniques. Tests that require to stick things in your mouth or in your nose maybe can be substituted from a sensor listening to your voice, for example. And obviously, it's more sustainable if we can avoid to use things that we use just once. If we can recycle or reuse digital technology, then this might become unsustainable. Obviously, we need to consider that batteries of these devices are not very sustainable, but the idea is that we won't be throwing away a lot of plastic, for example, every day by doing tests. And so this slide is a bit perhaps more computer scientist oriented. I'm talking about the challenges that we still have in making mobile health a reality. And so, of course, these devices that people wear, let's keep a watch in mind, have a number of sensors that can be used already to detect a number of physiological features. And you probably know that quite a bit, but we'll talk a little bit more about that. But also, technology is trying to advance also the discovery of new type of sensors, probably collected from different parts of the body. For example, on Wearables, we're trying to add additional sensors or use sensors that have not been used for one particular purpose for another. For example, we're trying to use the microphone that is already on the Wearable to see if we can collect heart data. Some of these devices are resource constrained. And so the idea of collecting data from them and then sending data, analyze data, sending data back could be an issue. So that is, for computer scientists, an important problem. Then there are some questions that need to be solved by an interdisciplinary team. For example, how frequently do I need certain type of data for a problem to be solved? How frequently do you need digestive sounds from the belly to understand if there is a particular disease or if the person is getting better or getting worse? Where do we do the computation of the data? Can we compute the data analysis closer to the user? This is linked to another bullet point that I have here, which is data privacy. Obviously, this data is location, acceleration, microphone is very sensitive. And so working with this data means almost like working with normal medical data. And so there are questions, are we really wanting to collect all this data, or can we develop machine learning models that run closer to the device and allow the user to be in control of the data? Is it possible at all? Then, of course, you might be aware that to make sense of such large data sets, one might need to create machine learning models. To create machine learning models, we need data with labels. In other words, let's use the example of audio. I have an audio sample from my voice, and someone needs to have labeled that piece of voice saying, oh yeah, this person is healthy, or this person has this pathology. For the machine learning to be able to learn, to train on existing data, so that it can then, when given another sample of another person's data, it can then predict, it can then say, this person is sick or this person is healthy. And the labeling of data for this kind of wearable data is actually very time consuming. It requires skill, like medical skill possibly. And we are coming up with techniques to allow us to work with less labels, to label just a portion of the data and still be able to train with larger data sets. Data sparsity, probably something that I don't know how relevant it is for you, but it is difficult to collect enough data for enough points to build this model. So that there are other challenges related to how much data you collect. And all of these techniques are related to building better models for machine learning for this data. This data is obviously often continuous. It's a time series data. And so building new machine learning that applies this data is challenging. And I already talked about data privacy, but I want to concentrate, perhaps especially for this audience, on the last bullet point on this slide, which is related to linking the data to clinical outcome. So because this is new type of data and possibly at a granularity that has not been seen before, making the link between the data and the pathology, the data and the disease progression is actually not only difficult for me because I'm not a physician, but it's also, from what I've been told, difficult for you because you never had this sort of data. I'll give you one example. When we talk about using voice to diagnose from voice, possibly respiratory pathologies, I've talked to doctors and they tell me, well, we are used to auscultate, we're used to hear from the stethoscope, from the lungs, but we don't do analysis from what comes out of the mouth, the voice coming out of the mouth. So techniques might need to be changed and adapted to the kind of input that these devices are now able to offer. And you will see some examples of this in the rest of the presentation. And so I just put together a slide with lots of examples of devices that we see. Some are attached to our body, but some are also attached to our environment, and they can listen to us instead of being attached to our body. One thing that perhaps you might not be aware is that for this sort of techniques to work, we need to consider that they need to work everywhere in the world. And this is quite an old graph, but it gives an idea of the different connectivity that people experience in different parts of the world. And so building technologies that work in different parts of the world might require different approaches to how you send the data, where you do the computation, and where you do the analysis for this to really work for scalable, affordable public health everywhere. So this is a graph that shows the different level of connectivities. You see in the US, there's a lot of yellow there, which means they have good connectivity, good Wi-Fi, and even 4G at the time. This is already, now it's 5G. But in countries like Indonesia and Nigeria, it's more like blue and possibly light blue. So connectivity is lower whenever it's there. And although things are improving, we need to consider this when we develop the technology. Now, what's in our phone? And this is the back of a Samsung phone with lots of little chip bits. And so I generally here list some basic components that are in these devices. So there's an inertial measurement unit, which is probably mostly known to many of you as a mechanism by which you can count your steps, because there's an accelerometer there. There's also a gyroscope and a magnetometer. And so you can make sense of the user activity through this particular type of sensor. There's a global position system, which is what we use for location. And this is often combined with radios such as Wi-Fi for better localization indoor, for example. We can't use GPS indoor. There are cameras, there are proximity sensors, so when you put your phone close to your face. There are microphones, and we'll talk about them. And there are a variety of radios, starting from your cellular radio to Bluetooth, which allows you to connect to other devices, or see which other devices are near you, so could give a view of aspects related to your social life, and then Wi-Fi. The processors in these devices are actually quite powerful. We have a CPU, we have a GPU, in fact, that if used well, is quite powerful in doing computation. There are also co-processors specifically designed, AI processors to be designed to compute machine learning algorithm on the device itself. So it's quite powerful. In fact, this particular device is more powerful than my first computer, which probably tells a lot about my age, but we'll skip that part. And so the basics of mobile health, as I've seen it through my career, was the use of this device able to interact with the user. Even just that level of, can I collect data about the user, about their demographics, about their medical history, and then maybe send them questionnaires and send them advice. I have a couple of projects working in this area. One was we're still working on in terms of smoke cessation. People wanting to stop smoking and wanting to get advice. Smoking is often very habitual, so related to where you are, with whom you are, time of day. And these things can be kind of harvested from the phone of the user, and particular tailored messages that we develop with psychological health psychology, have been delivered, can be delivered to the user to help them improve their life. And then there are studies on how much of this help, because after a while people get habituated, and if you see the same message all the time, that's not very useful, and so that doesn't work. We work also with medical adherence applications, trying to understand if the user is taking their medications, how to help them improve taking their medications, and logging this sort of information. This could be done, as I said, the basic is just interacting with the user through this device, which is already in their hand. The less basic approach is to add the sensing, realizing that the user is now at home, it's 8 p.m., and so that's a good time to send them a message or something. We're seeing through the pandemic that actually the use of medical app has improved. These were not very smart apps, but they were apps that the user used to interact and make sense of their personal medical data. But this is kind of giving a hint that actually remote monitoring is the future, and we need to power this up. There are many, many devices that are specifically wearable that are coming out. In particular, we start seeing Oura rings that monitor temperature as well as heart already on your finger, smart belts, smart pants, and things. Obviously in our hands already, things we wear in our ears. The watch itself is more and more able to monitor the functions that I list here, but I should highlight that there are discussions about the level of accuracy that these devices are able to get. Some of them are already medical grade, but most of them are considered not medical grade. But then the question I pose to the audience is, when do we really need medical grade? I guess my argument here is, because you're able to get so much data from a user, like sleep, for example. If I get a year of data of a person's sleep, do I make better sense of their life than if I get one night in a sleep lab with PSG polysomnography data? Certainly this is a debatable question. The sleep data, the sleep monitor might not be accurate on this watch or on whatever device you put on your body, but it might just be better because you get more data. You might be able to, one night you might get it right, the other night you might get it wrong, but generally might be enough data. There are things that are coming. Blood pressure monitoring, for example, is an example of it. And I like to talk about earables, as I call these things in my ear, because they've been defined as the next computing platform after smartphones. Some colleagues have defined that. And they've also decided that they've also tried to do blood pressure monitoring from them. So that there are lots of techniques starting to come up that would generally have been quite interesting to use with this technology. And we, in fact, also work in this area. So the thing that I think is coming is also having more sensors attached to your body, possibly to fabric and chips embedded in fabric that communicate with your devices that you have already wear. So now for the rest of the talk, I want to talk about various projects. Some are mine, some are not mine, that relate to the use of some of the sensors I've described for the analysis and diagnostics of illness. In particular, I'll concentrate on audio, talk about the voice as a predictor of health and heart sounds coming from the body, and then I'll describe the COVID and respiratory disease study that we have been doing. I will then hopefully have time to talk about Alzheimer and navigation, which is a project that we have also entertained. So, why sound? Well, as I said before, microphones are embedded in almost every wearable device that you can, the people are wearing, watches, phones, earables. So they're already there. They're also embedded in a lot of things in your household already because they're very, very cheap. And so the scalability and affordability of anything that uses sound to understand and diagnose and progression of disease is very feasible. Also, as you see on the right, I like this picture, the microphones of these devices sit with us all day. And as I've repeatedly highlighted, the importance of having information coming continuously, or at least at regular intervals, is probably something that the medical profession has not seen for large populations. And this is what I think is disruptive. It's really a disruptive technology. And this is not only true for microphones, of course. We've seen people using Fitbit and acceleration to monitor public health or to understand population health. So first, the voice. This is an MIT Tech review of January 2017 that highlights the possibility of voice to be diagnostic of post-traumatic stress disorder or even heart disease. And obviously since then, and even by then, there were papers and technologies that have been developed in this sense. So here, just to give you an example of things that can be done, I want to highlight a couple of projects this is not my project, but I thought it was interesting to introduce the kind of techniques that can be used. So coronary heart disease is something that probably is well known by the people listening. And so, plaque building in your arteries and restricts flow. Can we predict that so that if we predict it early, maybe we can help? And the idea here is that by being able so these changes in your arteries and restricted flow imply some changes in the respiration pattern. So irregular breathing, increased muscle tension in the vocal tract. And so participants' voice have been collected while they were pronouncing certain vowels to be analyzed. The features, so here is where I give you two slides on signal processing, let's say, right? So what has been used by this study is the fundamental frequency, which is the rate of the vocal fold vibration, so how much your voice is vibration. And this fundamental frequency average is extracted and used as a pattern for this signal. So here at the bottom, you see the kind of the period length of over time and the amplitude of the signal. This is a speech signal. And the idea is that the frequency, the fundamental frequencies is 1 over this length of the signal period. And so aspects that you can start looking at in this sort of pattern of voice, like another example of pattern here, are things called jitter and shimmer, which turn out to be very good indicators of how roughness, breathiness, and hoarseness of the voice are expressed. And in fact, here, the jitter expresses the changing pattern of the period length, and shimmer does it in amplitude. So the difference between this bit and this bit and how it changes over time. And the jitter is the difference on the y-axis, on the x-axis, on this and this, and how it changes over time. So by considering these two measures, people have, and I just cited one of the many papers that do that, that has managed to use these features to distinguish a control group with a coronary heart disease group. And here's an example of use of shimmer and of jitter, and how they are significantly different between the two groups. So the research is really going on in this sort of areas. And in fact, voice has also been used to understand patterns related to Parkinson's disease. Now, hypokinetic dysarthria is something that happens in Parkinson's disease and is characterized by characteristics that control the larynx and change the way in which the vocal tract is producing voice. And so by using some features, again, here, we could understand if a person has Parkinson or not with certain disease. This is a big table. I don't want you to look at this table, but you can see things that indicate that, for example, shimmer here is quite significant. It's in bold because it's able to indicate good results in understanding the disease between featuring, these are all features, fundamental frequency features, jitter, shimmer, and all of these have been used in machine learning framework trying to understand if the disease can be detected and which with accuracy. We'll talk more about, I have one slide explaining things related to sensitivity, specificity, accuracy for those that don't know what these are, but I'll leave it for a couple of slides later. So leave it with me for a second. One other thing, so we talked about voice, but now I want to talk about auscultation. So voice, perhaps I should say that voice is not something that I think, apart from perhaps a group in the medical profession, like people working with the vocal tract are working with, others are not able, are not trained to use as an indicator of health. In fact, most of the doctors are trained to auscultate directly from the body using the stethoscope. And so perhaps we need to introduce new disciplines to use this sort of machine learning and use the voice better in the profession. Heart auscultation is something very hard, I've been told, for doctors. In fact, there is a citation here saying that people get it wrong. People are not very good at auscultating to understand heart pathologies directly from sound. Although a stethoscope is something very cheap, it's just a microphone, and therefore it could be scalable and affordable if we had doctors that could use it. But it turns out that while for us, for our ear, this is quite difficult to do, for an automatic tool, this is actually quite simple to do. So what's the problem here? Having large data sets on which we can train models so that we can automatically help doctors to do this sort of detection of heart pathology, right, is what many of us are working on. This is a paper by my student Erica. If you want, you can find it on my webpage, where we use some data sets that exist already. So someone has kindly started collecting data to hear pathology diagnostics from sounds. And I think this picture is, I usually describe this, perhaps not for you as an audience. I don't need to say why the stethoscope is a good way to detect these heart pathologies that cannot be detected through an ECG. They could detect it with an echocardiogram, which is a very expensive technique to use. So trying to have something automatic that helps doctor to understand this is important. So how do we do that? Well, again, I don't want you to read all the features that we used, but we analyze the audio signal, like the signal process example that I've given you, under a number of features. And of these features, which are many, we reduce them to a smaller number of features per signal, and we try to understand if we can do this right. So here in the picture down, there are various works that have tried to do it. We show that our method that uses both traditional machine learning SVM or deep neural network examples can be used here. Obviously, the traditional machine learning works better when you have limited data, and that's probably also this case. And deep learning works better generally when you have more data to train on. What you have here in the various rows are the various precision of normal sound, precision of murmur, precision of extrasystole, sensitivity, and specificity. Now, I don't know if they're useful, but I will spend some time perhaps explaining what we really mean by precision and sensitivity, because these are important in machine learning for health. So precision is really trying to understand how many of the items that we have are relevant. So of all the items that we retrieve from the machine learning method, which ones are really the ones that are the sequence, let's say, if we're trying to detect the sequence. And what is very important here, and this slides I've taken, this example I've taken from Wikipedia, right? So what we call sensitivity is how many of the real sick are we able to get with our method. So here in the light green, we see that we get this 5. And so here the sensitivity will be this 5 over this large set of sick individuals that we haven't gotten. So it's not particular, it's almost less than 50% here, right? So we get only 50%. So sensitivity is very important to understand if we're doing something right. Being able to spot the ill patients in the method, with the method we use. So are we able to spot the people who had the murmur is what sensitivity would tell you if the model is well constructed. And so in addition to the work on heart that we've been doing, and we hope to collect more data both on audio and on voice, auscultation and voice. Because of COVID, we also launched a large data collection of sounds, respiratory sounds. And because we were all sitting at home, we thought we would do it with a crowdsourcing app. So what we did was to push out an app, and the page is still up and the URL is up there, where we ask people to contribute their voices and their data. And I will explain this in a minute. All the papers can be found on our webpage, and these are my 2 collaborators that have helped collecting this data. So what did we ask? We programmed an app that essentially asks people to breathe in and out for 5 times, cough 3 times, and read a sentence on the screen. So now many times I've asked myself, why did we come up with this random sentence? We could have asked them to vocalize better, and this would have been better. But people liked the sentence, it turned out, and actually they were keen to participate. So we collect a quite large data set that we are now distributing openly to academic institutions. So if you are interested, please read the page that on COVID sounds and see how you can get your institutions to get this data set if you're interested. And so what's the rationale here? Well, the rationale at the time was that this was quite a disease that affected the lower respiratory tract. So initially, you could see quite substantial differences between a healthy cough and a COVID cough. This is a spectrogram of, you can see it here. These are 3 coughs, 1, 2, 3, as they come from the user data. And this is a healthy individual. This is a representation of 2 very obvious situations. And this is a non-healthy one, obviously lots of mucus, and the frequencies are kind of spread at higher frequency here. You see more of that. And there's lots of patterns here too. So you know, in theory, one could use this. And then there have been theories mentioning, and these are a couple of papers from our colleagues in CMU, where they also, where they also seem to indicate that there were differences between a healthy voice and a COVID voice. This, remember, was at the start of the disease. So when really, I think the disease was affecting the respiratory tract, perhaps a bit differently than it is now. And so you see here all this nice harmonics on the frequencies that are kind of disappearing, or at least they're smashed down here at the bottom. Also, there are some potential patterns here at higher frequency. So these things have been analyzed, and the Wear group of scientists indicating that perhaps it's possible to detect COVID with this sort of audio signals. We've written a number of papers trying to see if a machine learning model could do this. Obviously, the disease has changed, and also I am not sure that you could distinguish the respiratory signals from perhaps a cold or a different disease. We have instead tried to distinguish the impact of perhaps asthma with respect to COVID, and there seemed to be a signal there. And we have analyzed possibly the ability to, if you are in a high prevalence COVID situation, then this tool would be useful because, the main diseases out there is COVID. So it really doesn't matter if, it could be flu, but actually there's a high probability it's COVID. And so this would be useful as a first cheap point of test for everyone. You can do it many times a day. And so that's how I think that sort of tool could be used. But I think the Holy Grail, and this is something I would be really interested to collect data for, is progression. Because I think we all have different disease kind of voices and modalities. When I'm sick, I sound different from when you're sick. But actually, the detecting from my voice that I'm healthy or sick is an easier task. So the ability of using this technology to detect progression, if I'm getting better or if I need to go to hospital, is what I think is the holy grail of this technology. Luckily for us, when we asked people to contribute data, we also told them that they could come back every couple of days and give us more samples. And so the graph here is a distribution of the users. These are the users. How many users have given us more than 10 samples is this. So here is zero, like essentially one sample. Many people gave us, just one sample, but this person. So this number of users, of course, how many people gave us 50 samples is up here. And so one person gave us 250 samples, which I thank in every presentation. So it came back every couple of days giving us samples. So all of a sudden we have a number of users that have given us more than one samples. And they've also told us, because these users, when they use the app, they tell us about the medical history, but also the ground truth about their test. Have you tested for COVID? Yes or no? Are you positive? Yes or no? So we know the ground truth. We know if they were positive or negative. And so I like to spend some time discussing this graph down here that shows a user over time. So this is day 0. And the crosses are our prediction, our model prediction. And the colors at the background are when the user tested. So the user tested generally positive in the orange screen and then negative in the green part of the screen. So at some point here after day 15, the user was negative. And so here, what's important for us is to see that our trend in the modeling would see a progression, which I think is very valuable information. We see here that the user is getting better and better and better. And before the user takes a test, we could see that the person is getting better, which I think is important, not just for COVID, but in general. And so even the reverse, is a person getting worse? The ability of using sound for this sort of behavior, health monitoring is, I think, very, very interesting. And so in the second part of the talk, which won't be very long, I will talk about another sensor and how that can be used to detect the disease, other diseases. So in particular, I'll talk about Alzheimer's. And we'll use the collection of outdoor mobility traces to understand Alzheimer's disease. And why do we do that? Well, Alzheimer's in the UK is is affecting a large part of the population, and I don't think it's. I know it's not just in the UK. And the other thing we know is that unfortunately, drugs don't really work. We can try to help at the early stages of the disease, and to do that, there are invasive tests that are lumbar punctures and other tests that can be used, but they're very expensive, invasive, and therefore can't be used at a population level. So we're trying to find proxies to see if we can detect Alzheimer's at early stages so that the drug manufacturing company can develop techniques to help the disease. So one of the first things that is affected by Alzheimer's is temporal lobe. the temporal lobe is responsible, as far as I'm told, for navigation. Hippocampus sits in the temporal lobe. It's the green part. You can correct me later. And so the ability of navigating turns out to be one of the first things that goes when a user starts to develop signs of Alzheimer's disease. And so first thing that we wanted to do is, if I'm given traces, navigation paths of people that have Alzheimer or mild cognitive impairment, mental cognitive impairment, then can I distinguish that from the traces of a healthy individual? And so we were lucky that a colleague had collected 33 participants' data using GPS trackers for 15 days. And they have given this cognition test, to see how they were scoring on the test as well. So we have some sort of ground truth of where they were. So the traces would look like things like I posted on the right here. And so the idea here is to develop algorithm machine learning to see if there are features in the movement of these individuals that would then allow to distinguish Alzheimer's patients from control. And so we looked at traces of returning to a point, so between 10 meters. So if you return 10 meters away, that's considered a return. Take between 1 and 20 minutes and have some length at which they go to. So the differentiating features that we find, and obviously this is, I'll show you, I think the last graph is probably the most interesting one, is can we use features related to traces to distinguish them? Segment similarity. Do people tend to have exactly the same path back and forward when they move or not? And it looks like the red one here, you can see that this is more distributed than this one. This one, the controls were a bit lower. Entropy, how people explore the space. And it looks like there was more entropy of exploration for the blue, for the controls, than the patient. We also look at aspects of spatial cognition, and looking at graphs. We usually move with a mental map of our space. And so we try to rebuild that mental map and map the traces. As you can see here, we build a grid around the trace and try to kind of map that as a sort of path through the various points, and looked at number of nodes that this map would have. Closeness centrality, which is a metric that is used in graphs to understand how connected the graph is. And we try to see if there is a signal in this data. Obviously, we only have 33 users, so it's very limited. And I'll tell you where we're going with this next. But so, the results are indicative, but I wouldn't say they are confirming completely. Now, the last graph I would really like to talk about is how this was effective for the various patients that we had. So we had 36 people. In fact, some were deleted in the study, but yeah, so now you see them all. And so on the y-axis here, you have the probability of being a control, probability of being healthy. And so the red line indicates if our machine learning technique were able to spot these healthy individuals. So it was able to spot all of these with a bit of variance, perhaps, on some of them, but not perhaps two of them. On the patient side, the patient should always be here, right? The probability of being a control should be down here. This is a binary task, by the way. And so the probability of being a control for these is right, but not for this two. Now, it turns out that patient 34 and 35 had quite a high result in their cognitive score test. So that means they were very early Alzheimer's patients. And so that indicates why we were confusing them. So now here is, the first path, but we would need to advance the technique to try to be able to even detect this very mild differences that we see between control and early Alzheimer patients. So as I said, this was done on a very small data set. The future is now that we have various apps, and we are a partner with other people that have apps to try to detect data using the devices that users already have. As I mentioned in this particular study, just going back, we used a GPS tag that was given to people to carry for that amount of time. But actually, we already wear tags. We are tagged by definition of using our mobile devices. So we could use an app on the phone to try to improve the way in which we are, tracking people at large scale again, and in an affordable way. And so here is all I wanted to talk about for today, but I hope we can now have a beautiful discussion about some of the aspects I defined and which I probably have been a bit fast in describing. You can find all the papers on my webpage and on our group page. And obviously, I would like to thank all the collaborators in my works, and especially all the students and postdocs. And so I will be happy to take questions if there are questions.
Professor Mascolo, thank you very much for this comprehensive and very informative presentation. You showed us a really broad perspective for the application of mobile technologies, being very inspiring. I also see it from our live chat as participants ask questions. So let's jump to the Q&A session then. And I would like to start with the questions associated with patient perspective. I see Mateusz asks if there are any specific technologies you consider the most applicable or acceptable by patients. So what is your take on this?
So I think it really depends on what you're targeting, but people would be keen to for their devices to be used as monitors of their health, as long as if there's something I'm already wearing and you're not changing my behavior to get the data, then I might be okay with it. Now, there's also a perception, like I've noticed that when I ask people, can I take all of your location data of the last 10 days? People look at me, this is too much. And it's obviously true. And as a researcher, I'm the first one to say that. So the way I like to explain it to the general audience is, I think we are in the clinical trial phase where there are side effects, and the side effects are privacy loss. So we will collect a lot of location data, for example, microphone data, for a large but not worldwide population. And that's the side effect. These people participating in the clinical trial might lose a bit of privacy by giving us the data, which we'll try to anonymize and do things with it. But then when we build the final tool, the final drug, the final tool that is able to monitor the location of these individuals, we might be able to put the model developed on their device, meaning that their location data will be analyzed close to their data, and their data will not fly into the cloud, will just stay with them. So I think there are solutions. Computer scientists are coming out with solutions to obviate this very, very big problem. I'm not sure that was the question. I think the question was more about the devices. I think people are very happy, as I see in many clinical trials are using Fitbit data from accelerometer. Accelerometer is not perceived as a very invasive device, invasive data sensor, and people are happy to wear something on the wrist because they do already. So I think that's already happening. However, I think the understanding of how much you can understand from an accelerometer about your life is actually underestimated. You can get a lot of very good information about your life if you wear an accelerometer. I'm not sure I'm answering. I'm happy to.
Yeah, it's a good one. It's perfect. And actually, the next question from Isabella is about how we can fit digital medicine in a routine clinical practice. But from what you say, is that it's already there. It's somehow connected with us, so it's there. Yeah.
Well, I hear lots of clinicians saying that now patients go to them with the data and say, well, I have all this, you can see my heart, I can give you the data. And that's almost too much data and is not in a way that clinicians can use it. So I think there's a big step between use of this data in clinical practice, because I don't think we've worked out the boring part of making this data useful to the clinical practice, which I'm not an expert on, but it's a big area. And so maybe I can talk about one of the studies that we're now pushing out on how we have instead tried to, I don't think machine learning is going to substitute the clinical practice. Some people say, oh yeah, we'll do everything automatically. Audio recognition in your voice will be done automatically. We don't need cardiologists anymore because it will all be done by collecting data about the heart and done automatically. We've done a study on our COVID data trying to ask doctors if they could auscultate the data and see if they could detect the disease or not. And then we used our machine learning framework. It turns out that the machine learning was useful for some things, but it was getting some things wrong that the doctors were getting right. And vice versa, the doctors were getting something wrong that the machine learning was able to get right. And so I really believe in a world where we're able to leverage the expertise of both cohorts, both the automatic and the machine learning. Another example was one where they were doing, I think, diabetic retinopathy from images of the eye. And the first screening was done by machine learning, by saying, okay, well, we'll pass through the images, through the machine learning. But then the difficult cases were sent to the medical profession. The cases where the machine learning was perhaps accurate, but was also uncertain about the results, because there's a measure of uncertainty, probability of doing things wrong. And then it was given back to the doctors, because the doctors are more skilled and could see what went wrong, what the machine learning couldn't see. And so we're not there in making this integration happen, but it would be really the right thing. But I think there's still lots of challenges. The data is there, but I don't think we're made it useful to doctors yet.
Yeah, actually, and this your response actually brings another question. What accuracy of a diagnostic AI system is considered efficient enough to be applied? Is there any I don't know, 90% efficacy or 95% when we can say, okay, this is good enough when we compare the AI system with a human? I don't know, 90% for diagnostic is fine. Is there anything like this?
So I think it depends. I mean, the sensitivity is what is important to have high, and I think there are standards like this antigenic tests that we use for COVID indicate a certain sensitivity, and perhaps having the same level of sensitivity on the audio would be good. But I think in addition to that, we have started working on combining not just the level of accuracy, but also the level of uncertainty. A model can spit out a very high accuracy, but have a very high uncertainty as well. Say, well, yeah, I think it's that, but actually my spread in probability distribution is this. And so I'm not very certain about the number I've given you. And this is almost even more important when you're dealing with health. And so you start seeing approaches that use that sort of probability to decide when the model is not really trustable. And I think in health, this is very, very important. So I know I've not answered with a number. I don't know that number. I think I would say, the level of sensitivity that we want would be the same that we want from an antigenic test, for example, or, those are the same rules. Maybe I don't see something.
Yeah. And, sometimes when I speak with colleagues and students, and actually I got abroad this question, how to translate, results of the AI algorithm into clinical practice, I mean, how to make a bridge, that's a question, how to make a bridge between medical and computer science community so they understand each other, because on the one hand, you have patients, and on the other hand, you have numbers. So, how to bring this together?
I don't know. I think our first step is to make the numbers be useful to the doctor so that they can get the patient on board. I think the direct link of machine learning to user, I think is a bit of a dream. I think we still need someone that puts it all together and understand the full pathology, the full picture, how it works, and then gives advice or is part of this conversation. We have not seen that yet. And it's, a number doesn't say the full story, but I think it might help. I really believe what the medical profession possibly is missing is this continuous input of data from the patient and possibly making sense of it. You see a patient, I imagine, not apart from when they're in hospital, and there, I think, ICU is a typical example where you have all the information perhaps. But for many diseases, we don't want to get the people in ICU. We want to do that much earlier. And having the data about sleep is an obvious one. If I have a picture of how this person is sleeping, sleeping is associated with so many health outcomes that if we have a view, even just partial, if this person is sleeping 4 hours a night every night, there's already enough information there.
Yeah, that's true. I agree with this, that this is like complementary, and we need this continuous data from devices at home, because this is the most of the time patient spends at home, in his natural environment. And Anya brought the question about the multimodality. Do you see that co-registration of these new biomarkers, like voice biomarker, in general, digital biomarkers, with a standard data, like the one from electronic health record systems or remote ECG monitoring, is the right way to do, or you would prefer to keep it separate?
No, I think, obviously, it would be really good if they could be integrated. I don't know of anyone who's done it already in their clinical practice. So I think it's a monumental challenge to then feed it into the clinical history in a way. I would like to go to my doctor and he already has all my graphs on the screen and he knows my medical history. That would be great. It's not happened yet. Is there any? You're asking the question because you think there's value in not linking the two, or?
I think there is a real value to link these two. Because, for me, I feel like digital biomarkers, especially vocal biomarkers, can actually fill the gaps, we meet in clinical practice. Not only remote monitoring, give us more information about the patient at home. I feel the vocal biomarkers, digital biomarkers, can give us kind of a clinical liquidity when we assessing patients. Sometimes we see the patient, we perform tests, and we hear the patient, and there is something. Some patients are more fragile, some other are more fragile. It's difficult to quantify it, but with these new technologies, I believe that we will be able to better stratify risks and understand the patient better.
Yeah, I agree.
Yeah, that's why I think also that combining data is the key. And there is a last question from Marek. For the digital therapeutic, how to build a research team? What competencies are needed to create, the team working together, like your team?
Oh no, my team is not. We are mainly computer scientists. We sometimes talk to clinicians like Thomas, but we mainly are computer science. I think it's quite challenging to be able to talk to each other, and sometimes we don't click. If I don't understand Thomas talking about various terminology, and if he's not able to make that connection, then it's difficult. If I, on the other hand, speak in computer science jargon, we don't understand each other. So there is a need for a team willing to have this sort of conversation, realizing the value of it, and not thinking, oh yeah, machine learning is gonna substitute Thomas, your history. We are making the algorithm that will do your job. I think we need people that understand that that's not the future for a start. That's step number one. And step number two, I think that the ability. So you need a combination of clinicians and computer scientists, possibly even signal processing expertise. And you might need also some. It depends if you are using off-the-shelf devices. So if you're building your own device, in which case you need engineer. engineers who are able to help you print the right device to do this sort of thing.
Yeah, thank you.
I think I'm saying obvious
much.
things.
Yeah, thank you very much for having this opportunity to collaborate with you. This is also a great, chance for us for clinicians to learn something new, but something really, useful for our patients. And that's why I'm very grateful that you found time to share with us your knowledge and being so much inspiring for people. Looking forward to working more together on the projects, and thank you for your time today and joining us.
Thank you so much.
Thank you very much. So have a great day and all the best. Thank you so much. Bye-bye.
Thank you.